Now, in the process of oogenesis, we have a female oogonium, which is the germ cell, that will duplicate its chromosomes to produce a primary oocyte. Now, this primary oocyte is what's going to undergo meiosis 1 in order to become a secondary oocyte, and then the secondary oocyte will undergo meiosis 2 to become a mature ovum. So with each transition, we're going to be halving the number of chromosomes. So for each meiotic cycle, we're going to be producing polar bodies. So the first polar body, that's our primary polar body after meiosis 1. The difference between the first polar body and the secondary oocyte is that the first polar body simply received less cytoplasm, so that will further form two secondary polar bodies, but those will degrade. The secondary oocyte, after it undergoes meiosis 2, it'll form another polar body which will degrade with the mature ovum that survives. The highest yield thing you need to know for the USMLE is that all of the eventual ova in a female are held in prophase of meiosis 1 until ovulation. Okay, they're all held in prophase of meiosis 1 until ovulation. Once stimulated at ovulation by follicle-stimulating hormone, the development of the follicle, following the release of the secondary oocyte at ovulation, it's held in metaphase of meiosis 2. Okay, so metaphase of meiosis 2 until it's fertilized by the sperm, and then meiosis 2 finishes forming the mature ovum. The eventual ova are held in prophase of meiosis 1 until ovulation, and then at ovulation they proceed to metaphase of meiosis 2, and then once fertilized they finish meiosis 2. Now for ovulation, once again, it's the LH spike that is going to induce the ovulation, and it's the follicle-stimulating hormone that will mature the follicle. So you have these developing follicles. They'll move from primary to secondary to Graafian follicle. It's important you know the Graafian follicle is the one that ruptures at ovulation, whereas the LH spike itself is responsible for ovulation. And Mittelschmerz is called middle pain. It's pain that will occur mid-cycle in some women, which is hypothesized to be either due to the rupture of the follicle itself or sometimes some adjacent peritoneal inflammation during the process of ovulation. But if they mention mid-cycle pain, it's referred to as Mittelschmerz. In pregnancy, you can see here in this picture the acrosome of the sperm, which is the head of the sperm, is actually derived from the Golgi apparatus. The flagellum is derived from the centrioles. Fertilization usually occurs in the ampulla of the fallopian tube within 1 day of ovulation, and following roughly a week is when fertilization will occur, and the beta-HCG secretion will stimulate the corpus luteum to produce progesterone. That progesterone secreted by the corpus luteum will maintain the endometrium. But interestingly, that progesterone that maintains the endometrium also negatively feeds back on the anterior pituitary to decrease LH secretion. Now, that LH is necessary for the maintenance of the corpus luteum. So in the absence of beta-HCG, so in the absence of fertilization, that increased progesterone following ovulation will lead to decreased LH and ultimately a non-survival of that corpus luteum, which is why we lose the endometrium. So that beta-HCG is necessary to maintain the corpus luteum when LH decreases. And recall that beta-HCG, or HCG in general, is structurally similar to LH, as it is to FSH and TSH. So progesterone and estrogen, necessary for breast development, they increase prolactin synthesis, but they also inhibit prolactin at the breast. So especially estrogen. So you get high prolactin levels during pregnancy, but we don't have any milk expulsion because of the inhibitory effect of estrogen at the breast. So once these levels decline following pregnancy, the prolactin will allow for milk production. In which meiotic phase is an oocyte arrested up until it is hormonally stimulated for ovulation? Prophase of meiosis 1. And then following ovulation, it's in metaphase of meiosis II until it's fertilized, which at that point it then completes meiosis II. As just discussed, it's the drop in progesterone following pregnancy that allows prolactin to be unchecked and to do its job. So we get lactation in turn. So you need to know that it's prolactin that stimulates milk production, but it's actually oxytocin that stimulates milk letdown. And prolactin maintains lactation, but in turn it suppresses ovulation because prolactin will inhibit gonadotropin-releasing hormone secretion, and GnRH is necessary for LH-FSH secretion. So in turn, the prolactin during lactation will suppress ovulation. So human chorionic gonadotropin synthesized by the syncytial trophoblast of the placenta. You've got the maternal component, which is the decidual basalis. Then you've got the fetal component of the placenta, which is the trophoblast. The trophoblast, you have that inner layer, which is the cytotrophoblast, and then the outer layer, which is the syncytial trophoblast. So HCG is produced by the syncytial trophoblast of the placenta. As discussed, this rescues the corpus luteum so that it continues to produce progesterone, and it's especially high in multiple gestations, such as twins, and in hydatidiform moles, and in choriocarcinoma. It's notably the marker for choriocarcinoma. Which three hormones share structural homology with HCG? And as we discussed, it's LH, FSH, TSH, and HCG, all of the same alpha subunit, but unique beta subunits. So the onset of menopause is a cessation of ovarian function and menstruation. Okay, so there'll be a concomitant decrease in estrogen, and it's usually preceded 4 to 5 years by abnormal cycles, oligomenorrhea, usually in the early 50s. And there can be other factors such as smoking, premature ovarian failure, polycystic ovarian syndrome, endometriosis. There's various factors that can contribute to when menopause might occur. What you do need to know is that it's follicle-stimulating hormone, okay, over any other hormone is reflective of menopause. If they ask you which hormone is most reflective of menopause, the answer is follicle-stimulating hormone, because inhibin production is going to be very low, okay? Now, it's not that LH or GnRH wouldn't be high following menopause, but FSH is always the answer. Same thing with premature ovarian failure. If they ask you what is the most specific hormone reflective of premature ovarian failure, the answer would be FSH. So signs such as hirsutism, okay, so hair and hair growing, masculine type of distribution, which is reflective of the decreased estrogenic state. Hot flashes, common for menopause. Hot flashes will also be described as vasomotor symptoms on the USMLE. There can be vaginal dryness, which can cause dyspareunia, so painful sex. Osteoporosis, because estrogens, which decline, are ordinarily protective of bone density. And coronary artery disease, because estrogens are vascular protective.